The next presentation will be Role of DCB in Bifurcation, Dr. Jasmine Vahora.
So, first of all, I want to thank on behalf of Unicare Heart Institute, Surat, for providing this wonderful opportunity to present our work here. So, today I am going to discuss about drug-coated balloon and a case describing the use of drug-coated balloon in bifurcation lesion. So, despite of being gold standard in interventional cardiology, drug-eluting stents still have some limitation. So, drug-coated balloons are novel treatment strategy for coronary artery disease.
Call post-Bental or post-CABZ, managing LMCA occlusion and stuck wall.
Only PCI is very promising technology. So, there are many indications. For instant restenosis, it is proven, like it is class 1 recommendation. Drug-coated balloon, there are many trials supporting use of drug-coated balloon in instant restenosis. Other indications are small vessel disease, and other emerging indications are there, like acute coronary syndrome and patients with high bleeding risk. Like we can give short duration of DAPT, 4 weeks only. Then diabetic patients, studies are underway. Then DNO, large vessel disease also, some studies are undergoing, like deluxe, debut, peptide non-STEMI. Then diffuse lesions, hyperpilar studies undergoing. Then calcified lesions, where drug-eluting stent is not expanding well, and long-term complications like restenosis and stent thrombosis, there are more possibility with drug-eluting stent. Drug-coated balloon only strategy is very useful. So now focusing on role of drug-coated balloon in bifurcation lesion. So we encounter bifurcation lesion in on an average around 20% of PCI procedures, and they present specific challenge in terms of technical complexity and long-term clinical outcome, and often compromised by side branch restenosis, suboptimal result with side branch. So drug-coated balloon is very useful. Like currently, there are two strategies: use of drug-coated balloon in side branch and drug-eluting stent in main branch. Another one is drug-coated balloon in both main branch and side branch.
Can we discuss the case?
Yeah. Can do.
Can we put down that light on the screen? But there's a lot of glare of the light on the.
So I'll describe something about technique of use of drug-coated balloon.
Start your case.
Yeah. So, proper pre-dilatation is mandatory for use of drug-coated balloon, because it is not for dilatation, it is for drug delivery. So, we can use other plaque modification tools like cutting, scoring balloon, rotablation, lithotripsy, but lesions should be prepared well before using drug-coated balloon. And pre-dilatation of lesions should be done with balloon 0.5 to 1 millimeter smaller than intended drug-coated balloon size. And 1-to-1 sizing between vessel and drug-coated balloon should be there. There should be minimum transit time to the lesion, and care should be needed while handling DCB, and because it shade drugs, and we should thoroughly study manufacturer's recommendation, and procedure should be ended with at least 30 seconds and optimally 60 seconds of drug single inflation. So our case, 64-year-old hypertensive male patient with chest pain underwent coronary angio at our center, and we showed bifurcation lesion in LAD and diagonal. As you can see, side branch is of smaller diameter. So Current consensus statement recommend provisional strategy. That is drug-eluting stent in main branch, and if required, then only we should go for another stent in side branch, or upfront two-stent strategy in suitable cases where side branch is of larger diameter or there is significant stenosis of more than 10 millimeter. So we decided to apply hybrid strategy. So association of DAB in side branch and drug-eluting stent in main branch to tackle long-term complications of osteal restenosis in side branch. So D1 lesion, I'm sorry, moving images I don't have as file got corrupted. So D1 lesion was crossed with run through wire, and then pre-dilatation of D1 was done with smaller diameter balloon. We are using semi-compliant balloon in our setup routinely. So 1.5 into 8 millimeter balloon we used to dilate the lesion, and the result was good. It didn't show any residual stenosis, any significant residual stenosis, and no dissection, and TME3 flow was there. So thereafter, we used drug-eluting balloon. So 2 into 10 millimeter drug-eluting balloon was done at 10 ATM with single 60-second drug-coated balloon inflation. So it also had good result. So vessel was dilated, and there was no any flow limitation or significant dissection or recoil. So thereafter, LAD lesion was crossed with 0.014 run through wire, and then pre-dilated with 2 into 12 balloon at 14 ATM. Then we deployed drug-eluting stent of 3 into 48 millimeter, and it was post-dilated with 3.58 balloon. So last result was good angiographic result with procedural success. So both drug-eluting stent and drug-coated balloon delivery and implantation was done within short time, and less than 30% stenosis in drug-coated balloon, and drug-eluting stent also good flow, and distal TME3 flow was achieved. So our message is the application of hybrid strategy, combining drug-eluting stent in main branch and drug-coated balloon in side branch, improve the outcome by reducing the total stent length and maintain the antiproliferative action, and long-term results are also good.
So
Thank you.
nice strategy. I think there are now going to be trials on this.
Yes.
There are ongoing trials. The only situation is whether you would be stenting the main artery first and then doing the DCB inside, or doing it
Ma'am,
first.
there is no
because
consensus.
because if there's a plaque shift
Yeah.
after doing your main branch
So
stenting, then what
actually,
would you do?
actually, there is no consensus
No
right
consensus.
now. There are no standard recommendation. So it is completely on our clinical judgment and our experience only, I think. So because final kissing balloon inflation also lead to some carina shift, and so it will distort the natural anatomy. So better to leave it as such after DCB.
But if there is a side branch to tackle, what are the indications of side branch
So,
lesion?
ma'am, if it is a significant vessel, then
How will you decide significant vessel?
the size of vessel is more. Caliber is,
Yeah, so here what was the size of the vessel?
it was around 2 millimeter.
Yeah.
So that's why we decided to use drug-coated balloon. If the vessel size is significant, then definitely we have to go upfront with two-strand strategy.
Okay, yeah,
Yeah.
thank you.
Thank you.